Thank you for taking time to watch this lecture. Hopefully I'm able to impart some very valuable wisdom about something I'm really passionate about, and that happens to be how you can combine clear aligner treatment with fixed appliance braces treatment and really improve the outcomes and the overall experience for your patients. And what got me started down this path was back when I was in dental school. I worked in an imaging lab, which we would take CBCT images of patients that doctors referred to us and kind of send it to them in a kind of a presentation form. And we were also just trying to find ways to utilize 3D technology to improve dentistry. Now at the time there were companies that would make you an implant guide, and this was essentially something that would snap onto the teeth. You would use it to drill your implant hole for dental implants, but they were thousands of dollars, and we were trying to find a way around that in order to make our own 3D printed guides. And I had this bootleg copy of something that would help me do it, and I was able to make to my knowledge, the first 3D printed implant guide, definitely in my school, but probably in a lot of schools. And the way I did it is I found out that my main campus had a 3D printer, and at the time it was called an Object, and the cost of this printer was $250,000. So fast forward several years, I'm in private practice as an orthodontist. We have these 3D scanners out now, and you can scan someone's teeth in a matter of minutes. Before, we would have to take a CBCT scan. Then we would take that CBCT scan and scan models of their teeth. I mean, it was very laborious, and so this was a huge improvement. In addition, the cost of 3D printers went down significantly from $250,000 to like $250. So, I mean, it was really a huge game changer. On top of that, I found I was doing almost all my own alignment with the aligner company I was using at the time, where I would, send them a case and it would be 20 aligners that have several attachments, and then I would say, okay, let me start from scratch and do this myself, and it would come back as 8 aligners, 0 attachments, and I felt like the outcomes were significantly more predictable. And then combine that with the fact that the aligner company I was using had combined with one of those direct-to-consumer companies, and I thought at that point, I'm done with this. I'm going to do my own thing. And I wanted to help other doctors do the same, so I created this group called Aligner Solutions, and with Aligner Solutions, it kind of allows me to help other doctors be able to implement their own clear aligner systems in their office. So that brings me to my overall presentation, and I got to move my floating head again. The name of it's called Ortho Synergy, which that anyone that's using the word synergy is definitely trying too hard, but it turns out it's really hard to think of a name for a presentation, and so you get Ortho Synergy. But really it's uniting aligners, braces, in a way that helps you just be more efficient with your treatment outcomes. And in order to do that, what you're trying to do is finish the hard movements with braces and finish the easy ones with aligners, because you're trying to focus on, like it says down there, you want minimal aligners, and to do that you need predictable movements. And so you get all the hard, unpredictable movements out of the way with braces. I mean, that is, I think, fairly obvious. So we're going to start, and before I get to this, the first thing you do, if you want to do this in your office, the first thing you need to do is start with retainers. If you're going to do it in your office, just start trying to make retainers in your office. Once you do that, you get used to the process of 3D printing. You get used to, when I say make retainers in your office, I mean through 3D printing. You get used to 3D printing, you get used to trimming, all of those things that are necessary to make aligners, but at a much higher scale. But if you get used to that, it helps out a lot. If you don't have the resources or the bandwidth or time to do it, you can always have another lab do it for you. For example, I use ArchForm for my aligner software, and you're going to kind of see some examples of it. But they have a service where it's very affordable. You can send them, you can do all the work, do everything yourself, use their software, and send for them to make the aligners themselves, and then they send it to you in really nice packaging. So there's a lot of options out there, but if you're wanting to get involved with it yourself, then you totally can do it, and if you need help, just let me know. But let's get started with finishing, because the next step after you learn to do the retainers yourself, you're going to want to get into finishing, where you've already done the treatment with braces, but you got some movements that you feel like, hey, this would just work better with aligners. Or the patient has poor oral hygiene, like right here, or you need them off for a special occasion. If any of those creep in, aligners, finishing with aligners is like a great option. It's also, there are just certain tooth movements, like I said, that work better with aligners, and you really want to focus on doing just crown movements and try to steer away from doing root movements. Specifically avoid root tip, root torque, intrusion, extrusion, and avoid movements that need attachments, because your goal is to do minimal aligners and to just maximize your predictability. So some of the areas where I really do a lot of finishing with aligners involves or is related to planned and surprise spaces. And what that means is there are some times where I'm dealing with, or that I didn't expect there to be a space at the end of treatment. I thought that they would, everything would be closed, and they come in and there's still space. And you want to avoid that debond doomsday where everyone's crying, everyone's upset. You can say, you know what, you got a little space there, but we'll take them off, finish with aligners, everything's going to be great, everybody's happy. The other thing is sometimes I have spaces distal to the laterals, maybe I have some slightly smaller upper twos, and I'm thinking, I want to just close that space, but I got this perfect class 1 bite, no overjet. I mean, I can just haphazardly go and IPR the lower, which we still do, and I did for decades, or I did for most of my practice, because I've been practicing for decades. But if I want to really be specific and know how much do I need to IPR and make it really smooth process, I can plan for that, take off the braces, there's still spaces distal to the laterals, and then we can do that, like I said, with the aligners. And again, everyone's happy. So here's a case where we did just that. We had this patient had some upper rotations, minor on the lower, a little bit of a kind of open, not ideal bite, and we get to this point where the bite's better, there is space distal to the upper twos, but at the time when I looked, I didn't see there being enough overjet to close that space without ruining my bite or creating heavy anterior occlusion. So I'm going to show you kind of how we work this up in ArchForm so you can get an idea of how you might be able to do it. All right, so this is Ava's teeth in 3D. I'm going to go to the original. So when we took the scan, you can see not much overjet right in the central incisor area, but we did have some overjet here and here, and maybe some traumatic occlusion right there. And normally when I don't have overjet, I'm looking at it to see how much IPR do I need to do in the lower to be able to close that space and not have traumatic anterior occlusion. But in this case, we're able to just reallocate where that overjet is. So on the lower, we're able to flatten out this front portion right here. So the overjet goes from there to there. And then on the upper, this might be a better view from here, you can see that the overjet specifically in this upper left side, we're able to condense that in. So pull out that lower premolar, which gives us space to retract, decrease the overjet here, here, and here, and that takes up a lot of space, even enough where we could do some IPR in those areas, although I just left it to where it would make that tighter, almost like virtual IPR. On this side, I did do a little IPR in this lower premolar area to reduce that heavy traumatic occlusion right there. And you can see how the canine, I rotated it to the mesial just a little bit, brought that back, and then reduced the overjet a little bit in that area, but was able to close that space without needing the IPR the lower and have, I guess, a good even overjet in that area. So this case, it only took 3 aligners, and I'll show you the finish of what it looks like. All right, so right here you can see occlusion looks better, spaces are closed distal to the upper twos, kind of a large embrasure, but there is contact there. Midlines are centered. And when I compare, I didn't get to compare. When you look at let me go back to, you can see how the spaces go from there to there. I think it turned out really nice. I also use it for allocating space in cases where the laterals are significantly smaller. In this case, she had these peg laterals, and I don't know about you, but when I do it with braces, it's like getting just the right amount of open coil spring in the right amount of spot, especially if you have your assistant doing it. It's like, are they going to put enough? Are they going to put too much? And so the great thing with the liners, you can get it pretty close, and then in a very few and easy way, or a very few amount of aligners, in an easy way, you can get those centered just right. So you can see in her case in particular, we had finished her treatment, a little bit class 2, but generally in the area that we wanted. And you can see that I have my laterals right up against my central incisors, and most dentists are going to want that more centered. In addition, they're probably not going to want that much space. So I'm going to show you how this turns out on the ArchForm software. So in the ArchForm software, this is where we started it. And within 4 aligners, I was able to move the teeth from there and just kind of move them back, and also improve the occlusion. A little bit too much overjet in this posterior area here. And you can see we went from here to here. I was also able to move the upper tooth lingually so that the preps for veneers or crowns wouldn't have to be, if they did veneers, hopefully as much, so that they can just add it to the outside and not have to reduce any of the tooth structure. So this took, like I said, 4 aligners, pretty easy, and gets the dentist exactly the amount that they want or need. All right, one of the other common reasons I use it is for incisor retraction. Now, some of this is related to if you have spacing, distal to your upper tooths, we're retracting incisors, but this is in specific relationship to like potentially upper incisor or you have incisor protrusion, or you got a significant overjet in a compromised case. I'm going to show you a couple of examples, but the goal really is to maximize retraction. If you can, maintain a class 1 occlusion, and you just have your retraction movements can be a little more accurate. For example, if you're trying to retract teeth and you're trying to maximize the amount of retraction, well, the worst thing that can happen is you're power chaining and you maybe have some area of occlusion that inhibits the retraction movement and instead turns into protraction of your posterior teeth. Aligners, you can account for that and really watch out for, is there going to be any occlusion that gets in the way of our movements? So in this case, I had a patient, class 2 bite, significant overjet, specifically in the upper right one. You can see there. And she also had this lower right 6 that was impacted, or it's not erupting. Probably something to do with that curved root. We ended up determining that we could not save it, so it was extracted. But we also did some phase 1 treatment just to improve the aesthetics. And then we finished that treatment. She didn't wear retainers, but luckily it held fairly stable. This is her several years after phase 1 treatment, and we're ready to address her phase 2 treatment, which is going to focus on bite correction. And I talked about removing upper tooths or several other options, surgery, whatever we might need to do to reduce the overjet, but we were going to try first by starting to align the teeth, maybe wear some rubber bands and see what that gets us. I think that lower right 2nd molar, the lower right 7 came in well, although inclined, measly inclined, and so we're going to upright that and really try to get the bite corrected. This is her overjet. You can see it's a significant amount, and although she's a class 2 skeletal, I wouldn't look at that and think that she needed surgery, and I felt like we could accomplish that with maybe some elastics, or at worst case, extract upper 4s, which we had discussed. Well, we got going in treatment, and she experienced, got the initial alignment. She's full step class 2, and she already has some gum recession on her lower left 1. And I quickly realized that the chances of us being able to do any class 2 mechanics would potentially only worsen that gum recession. So instead of doing that, we discussed extracting upper 4s, sent it to the dentist, and the dentist turned out to be one who was adamantly opposed to extracting teeth at all. And they were friends with the dentist. And so, I told them I don't have a lot of options to reduce that overjet. I don't feel like we could wear rubber bands. And before you judge me on this case and finishing someone with significant overjet, and we did fix some of the root alignment, but I at least got that lower right 7, got those roots uprighted. It looks so good. I just wanted to show one cool thing. So I'm gonna make a confession real quick before I get into this case, that when I decided to present a lecture on this, and I'm not a professional lecturer, I'm a private practice guy just like y'all, but when I decided to present for this case, I went through and was just trying to find cases I thought would represent or explain what I'm trying to portray. And turns out it's really hard, not only to think of a case that would apply to a certain situation, but to find records that are immaculate. And I'm going to just confess now that a lot of my records are not immaculate, or I might be missing one, or it's blurry. And it's something that turns out is really hard. So I give a lot of respect for those that are presenters all the time and have immaculate records, because keeping track of all that is kind of a pain. For example, this one, we got a lead apron in the way, all the things like that. But I wanted to at least, before I get to a point where you may judge me for my records or for my treatment outcomes, I just wanted to show how well I did uprighting that tooth before I get into the next part of this treatment. Okay. So we get to the stage where the dentist was adamantly opposed to extractions. She's a full step class 2, large overjet. I mean, you can see here the size of that overjet. I mean, it's big. And we're just trying to do anything we can and she has the gum recession. So we're trying to do anything we can to reduce as much overjet as possible and not affect the lower incisors or any anterior movement of the lower incisors. So here is the case. I'm going to put it at the stage that she comes in at the end of taking off braces. And you can see, I mean, the pictures probably didn't do it justice, but that's a large overjet. And again, I know we could have gotten a great result with extracting upper 4s, but this is kind of where we are now. So in order to reduce as much overjet as possible, I mean, you know the answer. We need as much space as possible. So I have a IPR system. I usually try to limit it to 0.3 millimeters IPR. It's a really cool system where I have like these sequence of discs, and I think it works really well. But essentially go through and plan on doing a lot of upper IPR. Now I try to, when I can, if I know I'm doing a lot, I might leave maybe a little 0.2 millimeters instead of 0.3, so that if I need to adjust anything, I still have room to make those adjustments through IPR. But in this case, I just wanted to retract as much as possible. And I did, even though I said I didn't want to advance the lower incisors at all, I did do a little bit of advancement of the lower incisors, and I'll show you what I mean by that. But I did 0.3 millimeters from premolars to premolars, and you can see the change in overjet. So you go from there to there. On the premolars, I just push forward, or between the 3 and 4, lower 3 and 4, I just push forward a little bit just to reduce that overjet, and I feel like that's still in a tolerable range, and I'm probably not going to affect that gum recession much. But if you look at the difference from underneath, you go from here to here. I feel that that's more tolerable. The other thing you can do to really reduce that overjet is you expand at the canines area. And again, they stick out too much, but it has a better look, and you're able to retract the upper incisors. I think in this case, it's some mild expansion, but nothing crazy. And if you want to look at kind of a, let me get rid of these other markings. If you look at like a superimposition, you can see where those were and then where they came. So a viable option if you're trying to reduce overjet as much as possible. And okay, like I said, I gave that disclaimer. This case we just did a little bit ago. She comes back in a week. So it may be after you've already seen this, but she comes back and I'll get some after photos that you can really look at the difference. But I do have this next case I'm really excited about. It can show you the difference of how much you realistically can get with IPR and retraction with aligners. So in this girl's case, she had a lot of crowding. And I had originally thought, and I think she has a great profile as is, but a lot of crowding, and I had suggested we extract upper and lower first premolars. And mom didn't want to take out premolars, and she was pretty adamant about it and really asked, are there any options that we could consider besides extractions? And I told her, I don't know, we could just try to see if we can fit the teeth in. I maybe have a little ray of hope that there's, it's a narrower arch, and she's not protrusive right here. And so I thought maybe we can just start expanding like with the wires and kind of open up space and see what happens. Well, it turns out we could fit all the teeth, but I like proclined those incisors a lot. You can kind of see, I mean, that's a lot of proclination. And you know, mom and patient were happy about it. I mean, they were excited about the alignment, but again, I mean, not many of us orthodontists get excited about that much proclination. We got it to the point where the bite was pretty good and the teeth looked straight, but she has kind of a more protrusive profile now. Not really lip incompetent completely. Teeth look good from this view and this view, but you can tell they're proclined from the side. And again, makes it look worse with those lips not touching, but they're proclined. So let me show you this case, and you can, hopefully I can redeem myself a little. All right, so here's our case. As you expect, I probably expect, we did a good amount of IPR and expanded the arches. So it went from there to there and expanded and retroclined the teeth. And really the IPR isn't much. Like when you do 0.3, it's pretty easy. The patient's comfortable. You try to get to like 0.4, 0.5. The contacts get really long, gets a lot harder. But 0.3 is a piece of cake. But you can see the difference. Let's see if I can remove some of these things here. If you go from there, so here to here, it's a big change. So I want to show you what that looked like in real life. All right. So here she is after the retraction. I think better profile. I'll try to show you side by side here. I think the teeth already just visually, I think they look better, not as proclined. If you compare it from there visually to there, I think it's a significant difference. And then if you look at the cephs from there to there, visually again, I think it's better. But I even did some measurements just to see like what kind of difference are we thinking about, are we seeing. So if you look at a before and after, where she started and where she ended before the aligners, I mean, I increased her her proclination, upper one to maxillary plane and lower one to mandibular plane by like 20 degrees. And then after we did the IPR and retraction, I decreased that by about 11 degrees. So really with the amount of retraction, I'm sure I could even do more by expansion, retracting more. But we were able to retract that by about 11 degrees, improve the overall outcome of her bite, the appearance of her teeth, just with aligners, and I think it was like 6 aligners at most. All right, so the next area I think you can make some really good progress and really help the finishing in your treatment is in and outs and rotations, but there's a few like simple tips that I found that are really great for these movements. So first, it involves staging and speed. So I'm going to zoom in here. Normally when you look at how much you want to move the teeth, the default is, you know, mesial and distal movements are 0.2, buccolingual 0.2. If you're using a fairly flexible plastic, and I use Zendura Flex, then I've increased most of these movements specifically because I'm moving the teeth in a way that is, I guess, more predictable. In and out movements, mesial distal movements, pretty predictable. If I'm doing a tip or torque, it's around the crown, around the center of resistance, and rotations, I feel like you can do a little faster. But the benefit about doing faster is it's less aligners, and you're also able to capitalize when the patient is most compliant. If you have 20 aligners, sometimes we just lose people at the end, versus if we have 6 aligners, it's obviously much better. You want to create space around the teeth you're moving. And you know, it makes sense, but I mean, create some legit space around an incisor. If you have one that's just being stubborn, you're turning it and it just seems like it's not turning, a lot of times you have some interferences as it's rotating with the adjacent teeth. So make some space, rotate it, and then close it. And it doesn't really add, I mean, even in this like particular case, it adds almost no additional liners when you're trying to do that. at most 1. You have to make sure your handles follow the long axis of the tooth. I call them handles. It's really the tooth axis, I think is what they label it, at least in ArchForm. But those handles, if they are tipped and your tooth is this way, but the handles are this way, when you rotate it, it doesn't rotate around the long axis of the tooth and your movements become less predictable. So make sure those follow exactly how you need them to. And then you just got to watch the occlusion. I'm going to play, let's see, I'm going to play this video for you so you can kind of get, let me go back. All right, so I'm just going to play this video and kind of walk you through it, but hopefully I'm not the only one that experiences this. But oftentimes I'll get a case where, you know, I'm trying to move a tooth. You can kind of see where I showed with the mouse. There's this interfering occlusion that is preventing one of my rotations from working all the way out. So if I'm going to fast forward a little bit, you have this rotation here, and you have this one spot that's hitting on the upper occlusion. So you rotate it, but their bite and their occlusion is going to push that tooth right back in. As soon as they take off that aligner, it's pushing that tooth in. So when you're doing this with aligners, you really have to evaluate the occlusion, make sure there's no traumatic occlusion. Or you may think like, oh, all I got to do is intrude this tooth. They're not going to be, there's not going to be interfering occlusion. But you have to remember, intrusion is really hard with aligners. Even if you have all the attachments in the world, sometimes that intrusion just doesn't play out. So then you plan on the intrusion only to realize that they're still biting heavily in the front and that rotation won't go away. So this gives you a really good idea of how you can plan for it. So what I do is I try to get it out of occlusion first, and then if I'm going to try intrusion, like I said, I make sure that occlusion's out of the way, then intrude, then minimum at least I've gotten one of the two types of movements that I'm trying to do. All right, so then the last thing that I want to show you, and there's several other reasons why I might use aligners, but this one's the last big one that I do, and that's just to improve the overall look and feel of the occlusion. Some movements are just easier with aligners. Specifically, and I think I mentioned it earlier, but the excess overjet in the canine area when it's unilateral just on one side, maybe they have like a slight asymmetry in how the jaws fit together, or they have heavy anterior occlusion, or you're just finishing with imperfect occlusion. They're still slightly class 2 or class 3, and you couldn't get that corrected. Maybe you had to get off early or take off the braces early, and this helps you get just into the kind of perfect, at least a more manageable and more comfortable occlusion. Like for example, this patient, she had fairly well aligned teeth. She had enough space for her teeth. Bite wasn't great, kind of an open bite tendency. She still had a couple primary teeth, and so that's kind of where she was. Then we put on braces, and it probably is at a time, maybe when I was trying to get a canine tooth too early, but for whatever reason, in this particular moment, I looked at this case and thought, oh my gosh, I have a long way to go. And this happened a little bit later in treatment, and she's getting a little bit of recession there, I think. Let's see. Yeah, a little bit of recession, maybe some kind of lower gums in the first place. Also, not great hygiene, and we just wanted to get done. So we get it closer. I close the space, get her bite better with braces. But we took them off, and you can tell there's still some elements where it just doesn't fit as good. So we take off the braces, and let me show you what that looks like. So she's currently in this stage right here where you can see, from the front, midlines aren't on, doesn't look great. Really has, like I said, that excess overjet in the upper right kind of canine area where that needs to be improved. And mostly just biting on her posterior molars. And then I'm going to show you, this is within 4 aligners, how it goes from here to here. And essentially, we keep the posterior bigger teeth in place and really push on all of these teeth. And so with a combination of this movement and settling, her teeth get into a much more manageable location. In addition to that, she had a lot of space over on this side, so I just took advantage of that by retracting this side and then using that to close the overjet on this side. So that's kind of where the space allocation went. This is another case where we just needed some finishing occlusion. She had some pretty good rotations in the upper incisors, rotations in the lower incisors. Occlusion not great. A little bit class 3 on the left. Some edge-to-edge bite in the anterior. Then you can see when I finished treatment, we had to take him off a little early for some school reasons. And you can tell it's not great. Like, definitely the alignment's better, but the bite isn't that great. Right side is, not great. Left side a little bit worse, a little bit more class 3. Still has that space between the lower left 3 and 4. And so we brought it to aligners. So I'm going to show you how this worked out. So she started off in this position. A little bit of heavy occlusion there, probably preventing some of the bite from closing down. The space, as we mentioned, a little bit of excess overjet here, a little bit of class 3 bite. And so within 6 aligners, took from there to here, closed up some of the space here, which helped center the midlines more. After that space closure, she had a little bit of extra overjet, did some IPR there, IPR here, just to get things to settle in better. So you go from here to there, here to there. And I felt like, even though she's a little bit class 3, this bite looks much better. So in real life, she ended up right here, which is about how we had it in the aligners. Midline's still a little bit off, still a little class 3 on that side. But let me see if I can show you. We'll go back a couple. If you look at that occlusion with the somewhat open bite, space, not great occlusion over here, and you go to this occlusion, I think this is significantly better. Patient was happy, and it took 6 aligners. So now, if I've convinced you, and hopefully I have, that you should incorporate some aligners into finishing, and you can be case selective at first, but you really have to decide, and let's say you're already doing the retainers in your office, or you already have a service that's able to make these for you. You got to figure out a way to make it efficient and fit within your practice without adding a ton of appointments. So the way I've done it for most of when I first started, is we would have them come for the debond. We would take off their braces. And I would look at, before I took off the braces, I would look, okay, can we do this with aligners? Take off their braces, scan their teeth, send it to, and I'll kind of go over this, but send it to my lab to get the case ready, line up the teeth. Then we would deliver aligners. There's a lot of extra steps. So I'm going to go through the different versions of that you could think about. So there can be a lot of extra steps, but the goal is really to have this just flow with the current amount of appointments that you have. So the ideal, and the way we try to do it in my office right now, is we scan at the visit before debond. If we have to make any minor adjustments, and we try to keep them minor, then we make them at that visit and we record them. Then we scan, digitally remove the braces, and I'll kind of show you how this looks. So the goal is, on the visit they still have braces, we scan the teeth. If we have any minor adjustments, we write them down. Then they come back for their debond appointment. We take off the braces, and at the same time, we're either delivering aligners or we're delivering braces or retainers, depending on what they need. So it ends up being really not adding an additional step, although you have to be selective. You can't do a lot of big movements. At least I don't do a lot of big movements right before or on that scan, because it's a little hard sometimes to predict exactly how the teeth are going to move, but it still works with the flow. The pros are appointment efficiency. It really doesn't add a lot, and you also get to capitalize on patient compliance. Patients are a little more likely to wear it right when you give them versus having them wear a retainer for a month and then saying wear aligners for a month, and sometimes you lose people. The cons is that brackets need to be removed digitally, and sometimes the gingiva can be an issue. Or if the final movements, you have to plan for those. So if you do any gum tissue issue, like I said, but if you do like a big step down, you have to anticipate how much is this going to step down, and so where should I start that first aligner? And so if that happens, let's say that you try to do that and the come in doesn't fit, you can still do it the way that I've done it for most of the time I've been doing this, which is, you take off the braces right here, scan the teeth. So that's all in that one appointment. They come back later that day for a retainer, so that's another appointment. And then they come back for aligners. Then you might have a follow-up. So it does add an extra appointment. The pros are it's very accurate scan because you don't have braces on there. And you can complete most of the challenging movements. You're not having to try to work that into the aligners. But the cons are it's 2 extra appointments and you might have compliance issues. A couple of other ways that are kind of hybrid ways. You could take off the braces, scan. That afternoon when they would normally come back for a retainer, you could have some of the aligners ready, whatever you could get done, and have that ready in the afternoon, and then they'd come back maybe later on to get the rest. But this requires extra appointments, and you definitely need a dedicated staff to be able to make those aligners. And then this way I think has a lot of value, is very useful, but you just have to be on your game, is where you take off the braces and you scan, and then that afternoon they get all of their aligners. And so it's nice because you get same day delivery. Maybe this is great for starting a case. You have less appointments than some of the options I discussed and more accurate scan, but the negatives are it's more appointments than at least the first option, and you need a dedicated staff to be able to make all of that for you. All right, for this last portion of my lecture, I want to jump into hybrid treatments, which honestly, I love finishing with cases. That's what I do the most of, but hybrids are probably my favorite part of this. Essentially what a hybrid is, or at least the way I define it, is you're combining braces and aligners either at the same time or from the get-go you have a plan of a certain period of time in braces and a certain period of time in aligners. And this works great for really isolating difficult movements and maybe applying fixed appliances in those movements, and then also maximizing the aesthetics by using aligners where maybe that matters most. And I would say in most cases that means aligners on the top and braces on the bottom. So this one, short time in braces and then short time in aligners. Usually it involves sectional braces. You might do upper, lower 3 to 3 only, or maybe one side for an ectopically erupting tooth I've done. You have a 7. Everything else is good, but the 7's tipped mesially. You get that fixed, and you can kind of finish everything with aligners. Or you're trying to really shorten the time in braces, so you're going to do maybe full braces, but you want to keep it as short as possible. Maybe in a situation where there's perio or root resorption, but you still need the benefits of braces, and then you finish with aligners. Well, this one, I love this case because I think it does a really good job of showing how you can minimize your time in braces and then switch to aligners. So this girl, she had a class 2 bite, and that missing, it wasn't missing, but I'll show you. She had an impacted upper right 3. But the upper right 3 had started to resorb the root of the upper right 2. So I didn't want to move the upper right 2 too much. I didn't want to keep her in treatment long because of the short root. So really spent some time staying off the upper right 2. And you can see, and this is with me not touching the upper right 2 at all, and I know I just skipped right to the end, and I wish I had a middle photo. But this is me, this is us, fixing the class 2 bite for the most part, not touching or bringing in the canine. We had it exposed, bringing in the canine, fixing the class 2 bite. All of that without touching that upper right 2. So this is just lucky happenstance that it was in line. But as we're going to see from the scan, it still turned to the right. There's still a little overjet, a few things that still need to be addressed. But we were able to do this, surprisingly, I think it took 11 months. So from here, let me see, here, went from there, again, like I said, class 2, impacted canine, root resorption on the upper right 2, then open exposure, pulled that tooth in 11 months, we had it to there. And then we took off the braces because I really wanted to move that too, but I wanted to be controlled movement and not have to worry about potentially additional root resorption. I think it fared well. There was root resorption there, and that canine, or that central took a little bit of a beating too, but overall healthy enough that it should last her entire life. So let me show you how we did this case. So she started out here. You can say this is without touching that lateral, but you can see even though those photos look good, she still had a good amount of space around it, and that tooth was turned to the mesial, and then she has the excess overjet. And well, I think we did a pretty good job of correcting as much class 2 as possible. I just didn't want to risk affecting these adjacent teeth anymore. So with the aligners, this is a really easy fix. Within 6 aligners, we go from there to there, fix the rotation, fix the overjet. I did add a little bit of IPR to the upper, but overall, I think a better finish than when we started the aligners, enough to justify doing it. So the final result, just like I showed you in the aligners, looked pretty much like that. The spaces are gone, rotations are gone, midlines are centered, and you can tell the overjet is reduced. And I felt like it turned out pretty good considering how we started. I love this case. So of the two, the more common option that we usually do is a situation where we do one arch in braces and one arch in aligners. So I have a few cases, and I'd say the most common is where you do upper aligners and lower braces. So a lot of times we're doing this in adults where they want optimal aesthetics, but maybe they worry about their own compliance, or I worry about it, or I just feel like it's going to be a better result if we have some braces. Now, obviously a case that can be totally done with aligners, but I do find that I run into that heavy anterior bite less when I'm able to do a better job leveling the lower incisors, which I think I can do better usually with braces. And so this scenario right here, we have bottom braces, aligners on top, and if you'll notice, there's a space distal to those upper twos, and that was on purpose. You did aligners on top. I wanted to create some overjet while we align these lower teeth, and then once those are aligned, and I've reduced the overbite some, overbite as in the deep bite, then I can kind of calculate how much maybe IPR on the lower, or if any, do I need to do to close that space back up with their bite still fitting together. Here's another case where she really didn't want to do braces, but I didn't feel like we could. We were going to try to level her gum tissue so she could do some restorative on the upper ones. And I didn't feel like we could do that with aligners. And although I'm sure it's out there and I've seen it, I just felt like we could get a better result with braces. And so here's her case. We put the braces on, did some intrusion on the upper ones just with wires, no tads or anything. Added some bonding in office, so you can tell it doesn't match, but it just kind of gives us a point or a level to shoot for. So then when we took off her braces, she still needs the restorative done, but I would say better gum heights. And then if she maybe had that one lasered, which I think we lasered, we lasered after this appointment, but it looked much better, more even. The incisal edges were better. She did have a slight open bite, and we used the aligners to extrude these the best we can, hence the attachments on there. But I think overall, let's see if we can go back to her beginning. She goes from there, and a smile like that, where you can see just the excess gum tissue right at the upper ones. And then we go to this, which I would say is a fuller smile. You can see more gum tissue overall, but once we lasered that, at least it had the better gull-wing effect and a better overall visual look compared to the first one. So she was pretty happy about that. So I want to show you some principles in this case, and a lot of it is just things we've already discussed, but how to take that finish where we had the upper braces, we did some aligners in the lower, and then usually the flow goes aligners on the aligner arch, braces on the braces arch. We'll do the aligners on the aligner arch, it's maybe 2 months worth, and then we're in a holding period while we work on the braces. And then as soon as we're done with the braces portion, then we take those off and finish the entire treatment with one set of aligners to just make sure everything matches and fits together well. All right, so this patient, she finished. We had the braces on the top, aligners on the bottom, and if you look more closely, and this is one of my favorite views, you can tell a little bit of excess overjet in the laterals. That one looks like it sticks forward more. Not great shape on the centrals. I think we bonded it while the braces were still on, just like I said, to give us a reference point. And then she could use a little bit more over, or a little bit deeper of a bite, like trying to close her bite in the anterior. So in 4 aligners, we're just trying to help those settle in the right place for the laterals. But in addition, it's more of a retraction, extrusion kind of movement like this. And the lower, we're going from here to here, just to give us more overjet of as we retract those upper incisors that, like I said, we can have a kind of a retraction, extrusion type of motion. But very subtle movements. And so, like I said, when you usually get to this point, it's aligners on the top, usually, not in this case, but aligners on top, brace on the bottom. We wear the aligners on the top for about 6 to 8 weeks. Brace on the bottom, that one goes, depending on what we need to do, it may go for a year. And then we take those off and we do aligners on the top and the bottom just to make sure it all matches, kind of like this. All right, so this next one's probably one of my favorite cases. I should save it for last, but I do have one more after this one, which I think still turned out really well. This is a case where she had orthodontic treatment from an orthodontist before me, and that had the practice. And this is how she finished. And you can tell like a little bit of an open bite here, but I would assume that would settle. My guess is she had, and this is the only thing I can make sense of it. When you see the case, you'll understand. My guess is she had some like heavy occlusion in the anterior and just wasn't biting fully in the back. That's what I think, why that represents that. But I wouldn't say like not, a little high angle, a little bit of adenoids, but not necessarily a mouth breather. Nothing that would stand out to me as super abnormal. She comes back, and after I've already taken over the practice several years later, and she has that size open bite, and it's a legit open bite. Like I said, not a mouth breather. I couldn't find any reason. The only thing that maybe made sense to me, and I have a hard time she did it enough to cause this, but she would rest her tongue between her teeth, which I do hear that when someone has like maybe heavy anterior occlusion, I do hear patients say it's just more comfortable. And maybe she was growing at the time and it was more comfortable for her to do that. And so she ends up developing an open bite for whatever reason. But she wanted to fix it, but did not want braces. And I don't know how I would correct it without braces. But I was used to doing intrusion with mini implants, and I thought maybe we could just intrude and then try to finish with like some Invisalign or with aligners. And I think at the start of this, I wasn't doing my own aligners yet. So they agreed to that, and I told her I didn't know if it'd work out, but we tried. So this is where she is. Again, a little airway constriction there, but I never noticed any mouth breathing, and she didn't report it. So we hooked up this device. I had my mini implant up there, which is just a vector mini screw, and I created this little, what I've usually done, create this little TPA that hooks onto it. I'm sure there are better ways, but that's the way I had it at the time. And then intruded, and then in this point, we had already closed her bite significantly, but in this point, I did hook on some 2 braces on her upper premolars, just because they were started hitting, so I needed to intrude those. But you can see, and let me just go back, when you see that, that bite to that bite with only that device, it's pretty exciting, I think. So with her case, right when we took off the aligner or took off the intrusion appliance and took off any braces, any fixed appliances, this is where we left her. Some rotations in the anterior, the excess overjet in the canine area. And I just wanted to make it, she was opposed to braces, but I knew with aligners we could, finish this up. So it goes from there to there. We push in the upper 3, which is a big deal, push in the upper left 2, and we're able to get it to that point where a little bit better occlusion. I think we did another refinement after this. So we go, but even adding to this, we push some of that in and just make sure the occlusion that when she bites down, it's going to finalize how the teeth fit together. So when you look at her final result, she went from, you saw the open bite in the beginning to this where the rotations are gone. Definitely better occlusion. I hate that brown spot. And maybe there's some torque in the canines that could be better. But overall, I felt like she went from a solid open bite to this with minimal braces and a few aligners, and ended up being a pretty good result for her. All right, last case. Still a really great case. even though it's probably my second favorite. So she was about to go to college, and she had impacted canines. You can still see the primary canines there. And they were good ones. They had really crossed over. I don't know if you can see. Let me zoom in just a little bit. But they had really crossed over those lateral incisors and central incisors. And she wanted something that would not show while she's in college. And I still convinced her to do braces. But what we did is an open exposure, left her canines, let those permanent canines erupt as much as possible. And then when she had a longer break, we took and removed the primary canines, and I attached some buttons and pulled these teeth into place. We didn't do any braces on the bottom. We just did the aligners as needed. So we got those teeth into place, and let me show you how it is. Now, in her case, we didn't do a lot of bite correction. You probably kind of tell here. She's a little bit class 2. We're really focused on just trying to get the aesthetic component and those teeth in place. Let me show what it looks like on the aligners. So we started off with this, and this is in 5 aligners, a little bit of extra overjet. She has a mild class 2. Canines, they were in a better position, but that could be brought in. She probably could use a little bit of expansion, and I try to include some of that. So you can see she goes from here to here. Midline's off a little bit more, a little bit of excess overjet. Flatten out the front, expansion on the sides, did unilateral IPR. You'll probably see in the last that she had a lot of excess gum tissue bringing that tooth forward. But overall, from here to here, I would say a significantly better result. So if you look at her final, next to close to final, we have fairly good alignment. And again, this is just doing those braces on the top and aligners on the bottom. Teeth fit together better. They're still a little bit class 2 though, like I said, but overall general appearance. The one thing I didn't like at the time was this gum tissue, and maybe this tooth was a little bit more retroclined than I'd like. But we ended up doing that gingivectomy, and I think that looked better. Although again, I would probably push that tooth out a little bit more, but she was pretty happy. So that kind of covers our in-office aligner treatment options of finishing with treatment and hybrid options. And in a future lecture, we'll talk about a few other ways that incorporate in-office aligners into my practice. But hopefully that was informative, and hopefully that got you excited about doing the same. And if you have any questions, feel free to reach out to me anytime. I hope you all enjoyed it, and have a great day.